In the ICU, there's this one treatment we often reach for when things get really bad: sodium bicarbonate. It's supposed to be a simple fix for a deadly problem: too much acid building up in a patient's blood. But here's the thing: this common therapy is actually one of the most fiercely debated topics in all of critical care. Today, we're going to pull back the curtain and find out why.
I mean, on the surface, the logic seems so straightforward, doesn't it? If the blood is too acidic, you just add a base, an alkali, to balance things out. Easy. But the human body is, well, it's almost never that simple. The real fight, the whole controversy, isn't about giving the bicarb, it's about everything that happens after it's in the bloodstream. So, to really get to the bottom of this debate, we first have to understand how the body deals with acid all on its own. And it turns out there are two major schools of thought on this, two totally different lenses to see this critical balancing act through. Now, the traditional view, the one most of us probably learned in school, is all about the ratio of bicarbonate to CO2. And if you look at it that way, giving more bicarbonate just makes perfect sense. But there's a more modern approach, the physiochemical view. It argues that the real thing driving the body's pH is the electrical balance of all these charged ions floating around in the blood. And suddenly, from this angle, our simple solution starts to look a whole lot more complicated. And at the heart of this modern model is something called the strong ion difference, or SID for short. The easiest way to think about it is like an electrical gap in the blood. It's the difference between the big positive charges and the big negative charges. And, according to this model, it's this gap that ultimately calls the shots and determines the pH. So before we even think about giving any drugs, your body's already on the case with its own powerful tools. First up, the lungs. They go into overdrive, making you breathe faster and harder to blow off that acidic carbon dioxide. Then, the kidneys jump in. They start pumping out acid and negative ions like chloride. And what does that do? It widens that strong ion difference, which is the body's natural, brilliant way of fixing the acidosis itself. All right, so that's what the body does on its own. Now, what happens when we step in and start pushing bicarbonate through an IV? Well, we're essentially hijacking that system, forcing it to change. And that, of course, comes with its own set of consequences. And not all bicarb is created equal. On one hand, you have the super concentrated or hypertonic kind. It works fast, rapidly jacking up the sodium and widening that SID. The flip side, it puts a massive sodium and osmotic strain on the body. Then there's the more dilute isotonic version. It works in a totally different way, by watering down the chloride. But to do that, you have to give a ton of fluid, which, as you can imagine, comes with its own major risk of fluid overload. But here is the absolute unavoidable catch, and it's buried right in the basic chemistry. When the bicarbonate we give finally meets the acid in the blood, it does its job, it buffers it. But look at what comes out at the other end of that equation. The inevitable byproduct is carbon dioxide. You are literally creating a new batch of CO2 right inside the patient's body. And that leads to the million-dollar question, right? All this extra CO2 has been generated. Where is it supposed to go? The only way out is for the patient to breathe it out through their lungs. Now, that's totally fine if you or I can just take a few deeper breaths. But for someone who's already critically ill, that could be a massive, massive problem. Okay, so that's the theory, that's the physiology. But what happens when you put this to the test in the real world with actual ICU patients? Well, for that, we have to look at the clinical evidence. And the biggest name in the game here is the Bicarb ICU trials. And the top-line result was frankly a little jarring. When researchers asked the biggest question of all, did giving bicarb save more lives? The answer was 0. No. Despite everything, for a broad group of ICU patients with severe metabolic acidosis, there was no overall survival benefit. But, and this is a huge but, when they started digging deeper into the data, a really fascinating signals started to emerge. In one specific group of patients, the ones who also had acute kidney injury, or AKI, giving bicarbonate led to a roughly 22% reduction in the need for emergency dialysis. And this quote from the source material just sums it up perfectly. The most consistent signal is reduced RRT utilization, whereas a mortality benefit remains unproven. In other words, it probably won't save a patient's life, but it just might save their kidneys from needing to go on dialysis. Okay, so you've got all this physiology, all this clinical trial data. How in the world does a doctor at the bedside take all of that and make a decision for the person right in front of them? Well, it all boils down to a very, very high-stakes balancing act. So let's be really clear.
Bicarbonate is not a routine everyday treatment. Its use is reserved for the absolute sickest of the sick. We're talking about patients whose blood pH has plummeted to a life-threatening level, usually 7.1 or below, and they're also in shock. In these desperate situations, it's used as a temporary measure, a way to buy some precious time.
And this right here, this is basically the mental math that's happening in real time. On one side, you have the potential benefits. You might pull them back from a dangerously low pH, and maybe, just maybe, buy enough time to let the kidneys recover or get them started on dialysis. But on the other side are the predictable harms, overloading them with CO2, with sodium, and with fluid.
So this brings us to the final, critical decision point. Before you even think about giving this drug, you absolutely have to ask these questions. First, can the patient's lungs actually handle the extra CO2 load we know we're creating? Do they have that ventilatory reserve? Second, are we actually doing something to fix the root cause of the problem? And third, are we truly prepared to monitor this patient like a hawk for all the bad things we know can happen?
And that leaves us right here with the central dilemma of this whole thing. Is bicarbonate a genuine bridge to helping kidneys recover, or is it just a risky physiological patch, something that makes the lab number look better while potentially creating a whole new set of problems? As the evidence shows, there is no easy answer. And making the right choice, well, it depends entirely on the patient right in front of you. Thanks for digging into this with us.